but I would just like to start by introducing our panelists. We might, I was going to start on the far end with Beverly and say, welcome Beverly, and just a brief introduction. That's okay. Let us know a little bit about yourself, Beverly.
Hello, everyone. My name is Beverly Baker, and I have the privilege currently of being the chair of the Older Women's Network New South Wales and the president of the National Older Women's Network. We were formed when we realised that the Pensioners and Superannuates Association was really blokey business, and the needs of women were completely different. And especially when, in those days, women were fighting to access superannuation that had been built up while they stayed at home and looked after their husband, and the husband went out and worked. So we set up an organisation that looked towards the needs of women, what women thought, what women want, and how they could retain their well-being, their dignity and their respect as they age. And we're still in that space, still trying.
Thank you. Thank you, Beverly. And now I'd like to introduce Dimity, Professor Dimity Pond. Hi, Dimity, and welcome. Oh. Dimity's already this unruly mob, really, between dropping the mics and Dimity photobombing the main speaker. So we've already met Dimity, but Dimity, hello again. And yes, if we could please just hear a little bit about yourself.
Hello, everyone. I couldn't resist interrupting the main speaker like that. I'm sorry, Kathy. I just thought for those of you who you were into a big numbers and graphs area at that stage, and having been a teacher at the university for some time, I know that some people glaze over with those. So I thought I'd tell a quick story. So I am a GP. I do look after lots of older people, as I explained then, and including not many in nursing home, and I'm getting older myself. So I'm very engaged with these issues, and particularly cognitive impairment's been my big focus, and what we can do in primary care to support people with cognitive impairment and their families. Thanks.
Thank you, Dimity. And also last but by no means least, Kirsty. Welcome, Kirsty. And thanks, Kirsty and Palliative Care, for all your help today. But it'd be great if you could let us know who you are and a bit about Palliative Care New South Wales.
Yeah, absolutely. So I'm the CEO at Palliative Care New South Wales, and we're a peak body, not-for-profit and charity. Been around for just over 40 years now. And really, we exist with that purpose of making sure that as many people as possible know about palliative care, how to access it. But really importantly, we advocate for that equity of high-quality palliative care for everybody, wherever you live and whoever you are. And so it was great to see in Kathy's presentation, she did have palliative was one of those 5 elements there. So that's what we focus on and what we advocate for. I'm one of the sandwich generation of, so I'm having many of these conversations with my parents at the moment around, that planning for aged care and that time and stage in their life as well. So I have lots of different perspectives from that point too. It's great to be here.
No, thanks. Thanks, Kirsty. And I would like to start by asking Beverly, what are your members of the Older Women's Network, saying about aged care? What's the conversations you're hearing?
Well, I had to laugh because, as Kathy said, it's not a lifestyle choice, but the conversations we're having is, hell no, we won't go, which is really the way that I feel and the most of the people in my generation are feeling. And especially when you look at the new Aged Care Act, which we're really caught because it's the only time human rights have actually been mentioned. And it's sort of like an Edwardian mansion. The front looks brilliant, but the dunny's a cesspit out the back. And the cesspit out the back is where the funding is all. And that is really the stuff that I'm thinking about, because I only have my home. I don't have any super. I was late working. Do I really want to sell that and give that to some rapacious private provider so they can put another story on their gold-plated yacht? Or do I want to give that to my grandchildren who are really struggling? Their numbers are a lot smaller than my children's numbers. They are struggling to buy a home. They are working in a gig economy. They have no permanent jobs or any of the stuff that we grew up with. Is that where I would rather have my inheritance go than have it go to a rapacious provider? So that's the sort of conversation that I'm having, because for my generation, we're not rich. Yes, there are rich baby boomers, but when you think of of people over the age of 65, which are all baby boomers, 80% of them are on a whole or part pension. We're not talking about a wealthy generation. We're talking about people who are and have done it tough. And the only asset most of them have is a house that is valued more than they would ever buy or ever be able to pay for it. Not because that's what they value it at, but that's because somebody else wants it.
Yeah, thanks. Thanks so much, Beverly. I can see lots of head nodding and clapping. So I think there's lots of people thinking about that as well. And
Yeah,
Kathy,
I
you
just
had a
wanted to
question.
comment on the family home, because one of the great issues that's been contentious was the way the government would move on the family home. It's actually exempted the family home from assets tests in the reform. So that's good. And I think that's really important. I have a problem with that though, because what they've done is to actually create an incentive for anyone who's got money to buy the biggest, fanciest, most expensive home they can and hold on to it, when we should be providing financial incentives and support for people, older people, to downscale into smaller homes that are safer and better suited to their purpose. But if they do, then they'll be walking into the land of big fees. So I'm pleased that the family home's exempt, because there are many, many people who only have a family home as their asset. But on the other hand, I think it has created a very perverse incentive, particularly in the middle of a national housing crisis, where older people are banging around, and I'm one of them, you know, big four-bedroom house, 2-story, blah, 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 and I'm there myself. Many other women are, when we should be downscaling, and financially we'd be crazy to do so.
And we would be competing with younger folks starting out as cashed up baby boomers, paying cash for a house that a young family is desperately trying to get into the housing market for. So it's really a wedge. But if you need to go into a nursing home and you are the only resident in your house, you're selling it, because the nursing home RAD price now is $750,000. And where I grew up, houses still aren't selling for that amount of money. So you're still going to have to sell your house.
Not quite. It's not quite as bad as that, but I mean, it's too complicated to go through, but it really is complicated. There are two options for residential care. One is a refundable accommodation deposit, and that's the idea that you put $750,000 to buy a room. And that's been called a RAD because you get it all back when you go refundable accommodation deposit. The home has had the advantage of having your $750,000 to invest, and they've kept the interest. And homes loved that and made a mozza in the days where interest rates were high. And in the last couple of years, before this last, in the previous decade where interest rates were really low, that's when all the homes started bleating about not having enough capital because they didn't get enough interest on your money. The alternative is and so the RADs under the new proposal have become PRADs, partially refundable, because when you go now, they will be deducting 2% per annum. So if you stay for 5 years in a $750,000 home, you'll be paying $75,000 and your family will get the rest back. But if you don't have that, the alternative is a DAP. I've got lots of acronyms, which is a daily accommodation payment. And the homes now, because they don't like the interest rates, want to get rid of RADs and they want more DAPs. And the DAP at the moment will cost you, for a $750,000 home, it'll cost you about $67,000 a year in rent.
Selling your house anyway.
So the house is considered, there's some rules around assets tests and how much of your house is included in your assets test. And I don't want anyone to walk out of here today and say, I've got the detail. Anybody needing in this situation needs the best financial advice you can get. But the devil is in the detail. You can come out of today with a broad understanding. I need to think, not just walk into a home and look at how the foyer looks. And aren't they beautiful flowers on the front counter, but actually walk out the back and have a sniff and really drill into those 5 domains I talk about and really understand the financial implications of decisions. But I also think to keep in mind, 14% of older people are in residential aged care, 86% are not. And we need to make sure that we don't just think that residential aged care is the only sort of aged care. The other thing that's emerging, I think that's very strong, is retirement villas. And I'm sure a lot of people saw 7:30 report last night. And their business model that they're aiming for is to start providing community packages in independent living environments, get that 78,000, pool it all, and become a sort of a cheap nursing home that doesn't have to meet the aged care standards. Because independent living and retirement living is regulated by the states because it's a housing service and not an aged care service.
So the good old Commonwealth state divide strikes again. And it also makes me think we do have one of the 10 questions brochures is about fees, which we probably have to update. But one of thank you for reminding us about the 5 domains, Kathy, because one of them, and just one of them, is health. And I'm just wanted to ask Dimity as a GP about that link between providing good quality healthcare in aged care and what does that look like for a GP or from a GP perspective?
So thank you, Anthony. And I'd have to say that there are some aspects of looking after older people, particularly in the community, but of course also in residential aged care, that are very frustrating for us GPs. So thinking about health, the average 85-year-old has 5 different chronic conditions. So we GPs need to, work through those and make plans for care in consultation with our patients for each of those, and they interact with each other. So unfortunately, the healthcare system is very siloed. So our older person is getting driven or somehow or other managing to get to 5 different specialists for those 5 different conditions, and they often conflict. And they don't seem to be aware of the other specialists' comments. So we're left trying to balance all of this stuff. And then that person is living in the community with support from aged care services. So they have often had an ACAT assessment.
So
Some of you will be familiar. And we don't know
what an ACAT is.
An aged care assessment team. Yes, they come and visit the person living in the community and try and assess what their needs are. So, and I'm confused about Commonwealth Home Support and my aged care, but I think it only happens at the my aged care level. Is that right, Kathy?
So that
I just want to pick up a little bit there. The Commonwealth created this thing called My Aged Care, which is a one-stop shop to get into the aged care system. Now, the sensible pathway for an older person is to go to their GP, and Dimity says, gee, it's time to give up your licence, but that's okay. I can refer you to community transport. That's how it used to work. It's not how it works now. Dimity or you have to go to My Aged Care and log online or wait online. And the idea that we've got one gateway into the whole of the national aged care, both at home and in a home, is just nuts, but that's beside the point. So there's a level of bureaucratic, that's that whole issue about how do you navigate. And that's one of the biggest frustrations, of course, for GPs.
And so all of that results in, we can actually do a My Aged Care referral, but it's an online thing. But then we never hear any more, except from our patients who go, someone rang and they asked a whole lot of questions. And then I said, what's going to happen next? And they said, we'll be in touch.
Oh, dear.
And then months pass. And I have no idea. I'm vague about the process, and I do not get any communication whatsoever. I don't know what there is a home assessment that's part of the ACAT assessment. I never hear anything about that. I don't know what they think about my patient, and they don't know what I think about my patient. So they don't know anything about the 5 different chronic diseases, because that's health and their aged care. So then they might not be aware, someone who looks very healthy, they might not be aware that their kidneys and heart and so on are not working very well, because they don't go into that level. So then they finally get some home help. Now, a lot of people have cognitive impairment getting into their 80s and 90s. And this system is complex, and they cannot tell me what their home help lady is doing. So I'm not allowed to ring My Aged Care and find out, because I'm not an authorised person. So I say, someone comes and they say, oh yes, a lovely lady comes. I go, okay, and what does she do? Oh, we have a cup of tea. And I say, yes. And does she do some, oh, I don't know, dear. I think she does potter around the house. No. Does she buy any food? I think my daughter does that. I'm not quite sure. Maybe she, do you get Meals on Wheels? Oh no, I hate that stuff. Right. I have got a whole lot of frozen food in the freezer, but I don't know how to use the microwave anymore. So, and this has an effect on health. There is no question about it that living on sort of bread and jam or whatever it is the person can manage to get for themselves, once their 17 hours has run out, and it's usually less than that, is not conducive to good health. So, and I don't know even what they're living on. And we don't do home visits anymore, because drug affected people tend to take to us with weapons so we've stopped doing that. So we don't know what's going on. So that is so frustrating. And the body is not different from everything else. It needs to be fed. People need to have socialize with each other. So I'm beginning to advocate for family members to come with their person as much as possible. Sometimes I even get my iPad and someone will Zoom in from the office, some daughter, poor daughters. It's 70% daughters, not sons. The sons are busy accumulating more super. Huh? The daughters, so the daughters may Zoom into a consult with me, but it all takes time, and we don't get paid very well for long consultations. So the system mitigates against good care for older people. And there's so many things that need fixing. And I'm so glad that Kathy is making inroads into some of those things. A CT.
CCTV.
I have trouble ringing my patients to remind them to come They can't make it work, a CCTV.
So that
It's too hard.
the question was, you know, why not install a CCTV in the home?
Invasion of privacy somewhat.
Yeah.
I mean, I'm not too sure I'd be happy with a camera in my home as I run around and sweep up the mess when I've got visitors coming. I don't think I want things that I do in my own home to be viewed like that. It's
So Hank, can I?
Yeah.
Sorry, we need a. Can we come? These questions are important, and I want to have a conversation about generation. No, but the problem is people just can't hear without a microphone. So just hang on 1 second. We'll start audience conversation in a second. But I did want to ask Kirsty, not just as the Xer in the X generation on the panel, but one of the other domains that Kathy was talking about that's needed was palliative care and good palliative care. And Kirsty, as the CEO of Palliative Care New South Wales, I just wanted to ask, this might sound like a silly question, but what is palliative care? What are we talking about when we're talking about palliative care, particularly in aged care?
Yeah, it's a really great question because we get many calls into our phone line exactly asking that question, what is palliative care? And I think it's really important to understand, and I hope that today we can also get across the point that if somebody mentions palliative care to you, your doctor, your specialist, it's not something to be fearful of. There are a lot of myths around palliative care, but it is an incredibly important support available to those who are eligible for it. And palliative care is for anyone with a progressive life-limiting illness. And, you know, that life-limiting illness, so it is, you know, going to shorten your life. It is progressive. It's traditionally in that last 12 months leading into end-of-life care. It doesn't mean, many people hear the word palliative care and think, I'm about to die, I've given up hope. And that's certainly not the case, and what palliative care can support. It's about managing and addressing your symptoms related to that life-limiting illness you have. It's not aiming to cure that illness or disease. It is managing your symptoms with a real focus on your quality of life. So it aims to help you maintain that quality of life. And, you know, I've got the orange heart on. This is our symbol for palliative care. And I like this as a visual because it talks to the beating heart that palliative care supports. And that support is physical support. So things like pain management, breathlessness, nausea, whatever some of those physical symptoms you may have as a result of that life-limiting illness. It's spiritual support, it's cultural support, it's emotional support. So it's that holistic, which Kathy also referred to, holistic support, providing you with person-centered care, but importantly, it's family-centered care. So it's aimed to support your family and also through to grief and bereavement support as well. Now, palliative care can be provided, ultimately, it should be able to be provided by any of your healthcare professionals. That's not necessarily the case in reality, unfortunately. Not everyone will need specialist palliative care, but specialist palliative care teams are available for those who have really complex symptoms and need more of that support. And it's available, there are community teams in residential aged care and in hospitals as well. So it's available in your home, and that's important to be aware of as well. The other question I often get asked is palliative care free? So palliative care is considered a human right, and palliative care, so if you have a specialist palliative care team coming out to you, that is covered by the government under Medicare. There may be some additional expenses if you need some more complex equipment needs or different things like that. But it is important to know that it is provided by Medicare, that specialist palliative care. But we would hope that it's a conversation that you would start with your GP, or your GP, we would hope, would start with you. Doesn't always happen. And they can also identify ways that you can get that type of support, that physical support, emotional support, spiritual support, which could be through community nursing and other avenues, that isn't always the specialist palliative care teams as well. So it's important to know that that's what palliative care is. And again, to Kathy's point, so there's a myth that it's only for people with cancer, sort of where it started, but it's progressed a long way since there. Dementia, Parkinson's, motor neurone disease, kidney disease, respiratory diseases, heart diseases, and now frailty is being identified as one of those life-limiting illnesses that we can absolutely provide support on.
No, thanks. Thanks so much, Kirsty. And I'd like to open some questions up to the floor. And if people have any questions, please let us know. We'll get a microphone to you. And I'd also say to the people who are watching us on Zoom, we can't hear any question from you, but if you want to put any questions into the chat on Zoom, we'll be able to ask it. So do we have any questions in the room that people would like to ask Kathy or any of the panelists? Yes, over here.
Thank you. First of all, I just wanted to thank everyone in this magnificent panel. It's all of you with the attraction for me to come along today. I also particularly want to thank Beverly Baker, who was the only person who spoke up in fierce opposition against the proposed so-called reforms once they were released to the public. Unfortunately, COTA and OPAN had been co-opted onto the panel, it seems to me, that had delivered these reforms, and are now finding themselves in the position of having to navigate people amongst all their evils. I'm particularly worried about palliative care. I'm a single person living alone. I don't own my own home. I don't have a family. I don't have super. I paradoxically find myself neither rich enough nor poor enough to benefit from this system. I recently attended a palliative care information session at my local hospital. They said the reason most people do not die at home is because you need realistically a team of 10 people, 2 of whom can stay with you 24 hours a day, presumably a spouse and maybe a roster of your children. At the same time, at the height of the AIDS crisis, there were 100 palliative care positions in St. Vincent's Hospital. Now there are roughly 5 to 15. The hospital out at Waverley has none. I've forgotten the name of it at the moment. Apparently, young dying men have much more traction than a bunch of old women. The government seems to me to be crab walking away from palliative care when people are absolutely helpless. I will not be able to navigate palliative care when I'm on my last breath. I am just absolutely outraged at these so-called reforms and really feel that old people need to devise their own political party to represent them. We have been let down by both sides, and I am just flabbergasted by what's in store.
I might just talk to the palliative care and yeah, it is, again, it's one of those classic examples of federal versus state. So palliative care is managed at a state level in terms of the provision of palliative care. And so you certainly have some of those challenges and intersections there as well. And you're absolutely right. It's good that you've highlighted, because it is the reality, what you have outlined, is that for people to remain at home to the very end, you do need that support system around you. Palliative care does not provide 24-hour nursing support, and that is sometimes what people might think it does, but it doesn't. It is teams that come in, make sure that you've got, your setup, you're comfortable, you've got what you need, the family are aware of what they can do as well, and those additional allied health is a big part of palliative care, but they are not there 24/7. It is important, and I think Kathy spoke to this as well, is there is a reality element here, and that is that reality that to remain at home, to the very end, you do need that support network. It is also a growing movement. We hear it. It's called public health palliative care, compassionate communities. Again, Kathy sort of mentioned this a little bit, but it's the importance of those support networks around you and how can you mobilize your own community of supports at that time to provide that. And it is going to be a growing area where we also need to upskill everyone on how you can provide that care at home. And it's things like lifting, moving people, showering, different things like that. And that is going to be the reality of needing to upskill, needing to be informed, aware, and know that this is there, because it is the reality. We continue to advocate for more inpatient units, hospices, dedicated wards and beds within hospitals to provide that holistic palliative care approach, because you're absolutely right, there isn't sufficient in the community currently. So, and of course, community palliative care as well alongside that.
So just Kathy wanted to,
Yeah.
a response from Kathy, and then we'll go. you.
Yeah, 2 points I want to make. First is about the profile of people who die in Australia. So let's just set aside, there's a small number of people who die young of traumatic things and rare cancers and all that stuff. Australia has got the 3rd longest life expectancy in the world. And we should be grateful for that. In my lifetime, life expectancy has increased by something like 20 years. There's about 190,000 deaths here in Australia, and about 60-odd thousand of those, a third of all deaths, are actually in residential care. 180,000 beds and 60,000 deaths a year. So every year, 60,000 people die and another 60,000 take their place. So 50% of all deaths occur in hospital. And hospital palliative care in Australia is in public units is free and generally very good. And we're published on this. We have some of the best pain and symptom control in the world, and it's free. The second thing I want to say is something about the nature of families and family compositions. A lot of the aged care reforms are predicated on the idea of 1950s husband and wife living in the house that they own, and the dutiful daughter who lives a street away pops in. About a third of older people in Australia live alone. Partly women and then nearly all women, of course, because the guys have popped off. Some of those are women by choice who've never partnered. The others is that we've got the first generation now of substantial number of women coming through who divorced their husbands along the way. So you've got about a third of women live alone, and about 20% of all older people rent. And you can't modify your house if you rent. So the idea of home mods and all the other things that are available are only available to homeowners. A third of people live alone. About a third of people are now in relationships which I call codependent. People who have been together, they're both 90 or 85, and they're equally dependent on each other. The idea that one's the care recipient and the other is the carer is just nonsense. The majority of people who age together are totally intertwined and dependent. And if one goes down, the other goes down. And these reforms are really light on for support for carers. Mm-hmm. And only about a third of people who are living in relationships, living in a home, often with family members or close family friends who can actually care for them. And each of us needs to work out which of those categories we're in, and therefore which are the realistic options for us, because the options available to somebody whose daughter lives around the corner or who's lives in an intergenerational household are very different to the person who rents and lives alone.
Thank you, Kath. And we had, do you want to make a comment or you had a question? We need the mic.
Lost track there. What if someone has got full mental capacity and physical capacity, but hasn't got family, and they then put her in an aged care facility? That's kind of taking away her right.
Can you just move the microphone just a little bit closer?
Sorry.
Perfect.
Someone who's got full mental capacity and physical capacity, just had a fall, but still is able to, you know, soldier on, and then they put her in an aged care facility, and they don't really take the geriatrician's report into consideration, because it's
Yeah, I'll pick up your point. People who've got full mental and physical capacity should go back to work, not to an aged care home.
totally.
Aged care is
Totally.
not for people because of their age. It's
Totally.
because they
I agree.
can't live independently. And we have to stop this assumption that there's all these people who are going to aged care by choice or because of their age.
Kind of robbing them of their dignity, you know?
I don't know, if I'm 90 and I've got no physical and cognitive capacity deficits, I'll be thrilled to bits. And I'll be out there celebrating it, not driving myself up to an aged care home.
Yeah, and they actually very quickly go downhill, deteriorate in an aged care facility. I mean, that's just my observation.
What we're facing, I think, is something that's been over 40 years in the making. For over 40 years ago, we signed a convention for accessible housing, which meant every single house should not have a hob. It should have accessibility from the street. It should have wide doors. It should have safety rails in showers. Had we done that 40 years ago, we'd be seriously talking about ageing in place, because rental accommodation, everything would have been bent to that. But because we don't look at ourselves as a society, we look at ourselves as a market, and it's what the market will bear rather than what the humans need, is why we are at this state now, and why I am so ripped apart by our current change in the Act. It's got nothing to do with people. It's got to do with profitability. And the reason that I'm torn, really badly torn, is that it is the first time we have an Act that actually mentions human rights. So do we walk away from that knowing there's a whole festering mess at the back of it? Or do we say, yes, we'll take that Act, and then we'll argue like the blazes to get changes so that we have legislation underpinning human rights, which will then impact on the Act? So it's really that kind of, we are fighting markets. Markets are not intelligent. They are made up of people, usually rapacious and usually looking at profit, rather than looking at human need. And that has been thus since somebody developed trickle-down economics and a market ideology, rather than a human-based centre of what humans need and how we as a community and a society provide for those needs. And aged care is part of an ageing process. And I am sick to the back teeth of hearing how other cultures look after their elderly. Why can't we? Other cultures don't look after their elderly. Do you know who look after the elderly? The women in those older cultures. The same as the women in these cultures are part of the sandwich generation, are the carers, are doing a whole range of things. It falls on the women to do that. And when we allowed, well, we're not allowed, we insisted that women join the workforce, rightly so, because who wants to be chained to the kitchen sink? We did absolutely nothing to replace or any provision for the workload that those women used to do in voluntary capacities, in caring capacities. We did nothing in the market economy to replace or even plan for the needs that were going to happen when those women themselves started to age and needed care. So this is a long term in coming. I'm hoping that together we can fix it a lot faster than it's come, because it's not the baby boomer generation that's going to be the problem. It's this generation. They outnumber us already. So don't say it's the baby boomers causing everything.
Oh, Kirsty.
They did.
I'm sorry.
I'm happy to be part of the solutions.
They did it. I mean, and it's because we as a generation ensured that our children, especially our daughters, were educated, that they had careers, that they weren't dependent on a bloke running off with somebody called Kylie and shattering their life. Oh, is that too much personal information there? Sorry. But really looking at making sure that our daughters did not make the same mistakes that we did, were not subjected to the same pressures that we were. We are now facing another issue because everybody's been in a sandwich generation. Everyone has been a sandwich where you've got kids and old people and everything. It's not a different thing. But the difference is that for this generation of sandwiches, most of them are working. Where for my generation of sandwiches, most of us weren't. So we had the time. We could take the time. We could, we'd had it. Not that it was financially viable for us or emotionally or intellectually stimulating, but it meant that we had the time. And the time is the one thing we don't have. It is the only thing we can price because it's the thing that carries wage and an income and your price, but it's the one thing we have not ensured there is enough of for other people to do the work that's needed.
So we have one question.
This was a question.
I've been listening to what everybody's been saying, and I'm getting more and more depressed. I get the feeling that governments deliberately make things difficult. That way we can't access it, and that suits them fine. And I'm hearing, palliative care, blah, 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 and what we have to do. And my life is I'm meant to age with dignity. And I'm not seeing the slightest possibility of that. But the one thing possibly could upset people to mention it, but I think it would be quite part of my dignity to choose when I go. And that is not being addressed by anybody. And I don't have to be in screaming agony with 6 months of a terminal condition, and I still need 3 doctors. Yeah. All I'm doing is living longer to support the rapacious people who are having old people's, making a fortune out of my old age. So what is anything happening in that direction in the old age community? Please.
It is, but it is very quiet because we know when the Voluntary Assisted Dying Act came in, there were a whole pile of people who were young and healthy that didn't want it for whatever reasons. It's the conversation that as an ageing society, we're going to have. And it's what I started with. The hell no, we won't go. That we are talking about the right to make a choice that when we can no longer live on our own, that we can have a big party, say goodbye to everybody and shuffle off without anybody who helps us, aids and abets us, being held to account and charged with murder. It's a conversation that intelligent people should be able to have. But like a lot of issues around morals, it's an issue that's very hard. And it was one of the things with the voluntary assisted dying that people were raising, that people would take it and use it for suicide rather than for assisted dying because they didn't want to die in pain. I don't think that's anyone's business but mine. And I think that as a mature society, it is something we should have a discussion around, religious beliefs notwithstanding, because like anything that does with a religion, that's between you and your religious belief. It's got nothing to do with anyone else. And I think that those conversations are starting. We're starting to look at advanced care directives, and people are putting things like that in their advanced care directive. If I can no longer make the decision for myself, this is what I want to happen. At the moment, they're illegal. They don't have to be followed. But that's simply a change in legislation. And if we all start working on that, and especially your generation, you outnumber us, you can do this. but it's keep reminding them they are more than us, that we could actually do something so that you can live and die with dignity.
And I,
We make that happen.
Suicide no longer affects life insurance. No, that's all been excluded from.
I might just comment on terminology. In Australia, we now have voluntary assisted dying legislation. So the emphasis is on the dying and voluntary, obviously, but the dying, that is for people who already have a condition with a life expectancy of less than 6 months or 12 months in some neurological cases. If you go to somewhere like the Netherlands, they have voluntary assisted suicide legislation, which allows a person of any age to say, I've had enough of this life, I'd like to die. And there are pros and cons about doing that. I mean, there've been some pretty horrendous cases in the Netherlands of, young women with anorexia electing voluntary assisted suicide and things like that. And we do need a very mature debate about it. I mean, I'm not pro or con it. I just think we need to be very clear that we do have voluntary assisted dying legislation now in all the states, but not in the territories. Thank John Howard, but in the states we do. The first person ever to die by voluntary assisted dying in Australia was a woman in a nursing home in Victoria. So the idea, that you can't actually separate these, it's up to the home, it's up to the hospital. It's seen as an individual issue and also an institutional issue. So the Catholic hospitals have made a decision they're not going to offer that service, but it's a choice that people need to understand they have a right to, and they might need to shop around, but not pay for it.
and the thing, as an organisation that actually was quite involved in advocating for voluntary assisted dying with Health Consumers New South Wales, I'd say to you, it was a long fight to get what we've got, and it is imperfect. And even with these restrictions, yes, a provider or a institution, while it may choose not to offer it, it can't stop anybody in their care from accessing it. And I know that's playing out in different ways and it's not perfect. But already we're seeing, so it's nearly a year since it's been introduced in New South Wales and a few years in other states. And already we're seeing that conversation about what's the next stage. And there isn't, like, the people who are advocating to get it over the line are now talking about, well, can we put it in, get things in advanced care directives if you are assessed for voluntary assisted dying and then lose mental capacity, well, you're no longer eligible.
And that's probably a good point for everyone to be aware of, that if you do lose capacity, then you cannot go through the application process for voluntary assisted dying currently. So you do need to have capacity the entire way through the steps and the process. So that's just for anyone that's new to VAD, then that's just an important thing to be aware of currently.
Children with
Anthony.
yeah. So
We have
I'm, as I said, so it's pleased that we've got a start, and those, well, I think it's more here. We want it here. I think we got here rather than here. But yeah, there's still a way to go for sure. And the people who are advocating are now also saying, well, let's, who's missing out here? So we had another question from the audience. I'm just aware of time and we might make this, who's got the microphone? So this will be the last question, but we'll be able to continue the conversations afterwards. So
it's not a question.
We're all outside. We'll all be at we've got our displays and our stands. So we're here for the next hour and a half.
It's more sort of comments. I think anyone can make a referral to the aged care website. It's not just the doctors. Like if you wanted home care service, you can go through and start the process. Secondly, I'd like to address your point, Beverly. I live in an apartment block that's about nearly 10 years old, and builders are building accessible apartments. I don't know how many there is in our block. There's 280 apartments, but quite a few have got accessible there's no hobs, there's railings, and there's accessible car parks. And the third thing, just quickly, I can speak to the CCTVs in people's homes. It's not at your age or my age where we're cognitively intact. I'm a retired nurse. So this family did have CCTV in the house because their mother was completely confused. So this way they knew if she had a fall, because she never remembered she didn't wear her personal alarm. She couldn't always find where her phone was. So it's horses for courses. Of course, at our age, we don't want anyone to be imposing on our lives. But when the time comes and your relative is still living at home, you're very happy to support them, even going in a few times a day. CCTV has its place. So I can just talk to it because I've had experience. Thank you.
No, thank you. And thank you, everybody. I know it's terrible to wrap up a conversation like this because it feels like it's halfway through. But the day is not over, and our panelists and Kathy are all sticking around. So I will invite you all to please stay around, join us for a cup of tea and something to eat. There's stands from various organisations. And why isn't this moving on? Now it's playing up on me. There we go. So I would just, as we just would like to wrap up the formal parts of the proceedings, would like to thank our hosts today, the Sydney Mechanics School of Arts, and the wonderful people who showed us in, Liz, Sophie and the team. Thank you for all your help. And Lisa, who's the CEO of Sydney Mechanics, will be here and around and available to talk to as well. I know some people here are members of Sydney Mechanics. I'd also like to thank the organisations who have some display tables, so please stay and talk to our exhibitors. There's information around a whole range of things that we've talked about today and some other things as well. So Health Consumers New South Wales has a table, so does Palliative Care New South Wales, the Multicultural Community Council of the Illawarra, so Celine, her group has a table, Quality Aged Care Action Group, Council on the Ageing New South Wales, and the Older Women's Network all have tables. Our other supporters who couldn't make it today, the Seniors' Rights Service and the Australian New Zealand Society for Geriatric Medicine, are also big supporters of the day. And we'd like to thank them as well. I'd like to also single out Kirsty and thank Kirsty for all her help. This started as a conversation almost a year ago when some bright spark thought it'd be a good idea to have a conversation around aged care. That was me, and that turned into me organising today. And when I was flailing a bit, Kirsty was able to come in and pull it all together. And so I want to acknowledge and thank Kirsty for that.
Thanks to you too, Anthony.
So thank you all very much. As I said, please join us for a cuppa and something to eat. And we'll all be around if people want to have some conversations and ask questions after.